Have you ever heard of a tiny gland at the base of your brain that controls almost every hormone in your body? That's the pituitary gland, often called the master gland. Now, imagine a slow-growing lump quietly forming there. This is what we call a pituitary adenoma. Though usually benign, it can have powerful effects on your body, sometimes silently and sometimes dramatically. A pituitary adenoma is a non-cancerous tumor that usually grows in the front part of the pituitary gland. These tumors are quite common and are often discovered by chance during brain imaging for other reasons. We tend to group them by size. First are microadenomas. These are less than 1 centimeter in diameter, followed by macroadenomas, which are larger than 1 centimeter, and lastly, giant adenomas, which grow over 4 centimeters, even up to 10 centimeters in some cases. But size isn't the only thing that matters. Some of these tumors release extra hormones, while others do not. There are two main types of pituitary adenomas. Firstly, functional tumors which secrete hormones. Depending on which hormone is involved, they can cause, example, higher prolactin levels lead to infertility or cause breast discharge. An excess of growth hormone can cause something called acromegaly or gigantism. An excess of ACTH will lead to Cushing's disease. An overproduction of TSH will result in overstimulation of the thyroid gland. Secondly, non-functional tumors do not make hormones, but they still press on nearby structures, especially the optic nerves, leading to visual problems and headaches, or low hormonal levels, and a condition called hypopituitarism. So, to diagnose a pituitary adenoma, doctors start with tests to check the hormone levels, followed by a full visual assessment. Then they'll order an MRI of the brain, which gives a clear picture of the pituitary. If an MRI is unavailable, a CT scan may be used, though it has less detail than the MRI for this condition. Treatment depends on the type, size, and symptoms of the adenoma. Small non-functioning tumors that don't cause problems are usually just monitored by your neurosurgeon. Prolactinomas, which are the most common, are often treated with medications called dopamine agonists, like cabergoline. These shrink the tumor and lower hormonal levels. For other functioning tumors, like those causing acromegaly or Cushing's disease, surgery is usually the first option. The most common approach is the transsphenoidal surgery, where the tumor is removed through the nose. If surgery doesn't cure it, patients may need radiation therapy or medications to control hormones. For large tumors compressing nearby structures, surgery may be urgent, and lifelong hormonal replacement therapy may be necessary afterwards. The good news is most patients do well, especially if the tumor is caught early. However, long-term follow-up is important. Regular MRIs track for recurrence. Hormonal tests ensure the body is producing what it needs. Some patients may need lifelong medications for hormonal balance. Recurrence can happen, but with proper monitoring and care, outcomes are generally excellent. So, while pituitary adenomas may be hidden, slow-growing, they are far from harmless. Whether you're a patient wanting to understand your diagnosis or a resident brushing up for rounds, remember, spotting the signs, checking the hormones, and coordinating care with ophthalmology, endocrinology, and neurosurgery makes all the difference. And now you know, big or small, A pituitary adenoma is worth paying attention to. Thank you for your time and have a blessed day.